We will speak about the bladder tumor part 16. Here we will discuss very important part of bladder tumor management is radical cystectomy. We will see the demonstration of this here.
Complete lateral removal includes removal of the prostate. Complete lateral typically through the uterus, the pelvis, but not the vagina as well. To remove the bladder, the surgeon will separate both ureters from the bladder. The tubes that connect to the bladder. The surgeon will also separate the urethral calcium from the bladder out of the body. During the procedure, the lymph nodes may be removed as well. Once the bladder is removed, the surgeon will interlink a new passing urine from the kidneys to the outside of the body. This animation shows the two most common spots urine, the ileal conduit. The conduit runs the tubes to an opening in the stomach. Urine is you will be given instructions on how to change the bladder. Type 2, the neo. A neobladder, new bladder, is a pouch created from a portion of your intestines to store urine inside. The ureters are to one end of the neobladder. The urethra connects to the other end, just like in your original bladder. You will pass urine through. Follow again.
So, as we see previously, radical cystectomy is the gold standard for treatment for a non-metastatic and muscle-invasive primary bladder urethral carcinoma. Radical cystectomy removes the bladder and the pelvic lymph nodes. In men, prostate seminal vesicles typically removed with radical cystectomy, and in women, the anterior vaginals and the uterus and fallopian tubes in the ovary, this is also typically removed with bladder. The reproductive organs can be spared in patients who wish to preserve sexual or reproductive function. If no neoadjuvant systemic chemotherapy is given, radical cystectomy should be performed within 3 months of cancer diagnosis. That's why, because it reduces the risk of progression and the risk of death from the bladder cancer. Radical cystectomy revealed incidental prostate cancer in 28 to 61% of the men. So that's with radical cystectomy reveals as incidental finding of the prostatic cancer in 28 to 61% of the men. Without neoadjuvant chemotherapy, 10% of cystectomy specimens are BT0, but with TURBT completely excised at 10% of the muscle-invasive tumors. Okay, so BT0 with radical cystectomy is 10%, but we have 10% muscle-invasive with TURBT completely excised. The worst prognosis finding in the primary bladder tumor in men is prostatic stromal invasion. Prostatic stromal invasion, the 5-year survival is 20 to 36%. Unless contraindication or contraindicated peripherally acting mu opioids, mu receptors antagonists such as alpha-MOPAN that should be used to accelerate the recovery of the post-operative gastrointestinal function. The side effect and complications, perioperative complication occur in 50 to 60% of the patient. Okay, that include infection, bleeding, require transfusion, alias deep venous thrombosis, intra-abdominal urine leak, a leak from the bowel anastomosis, and perioperative mortality is approximately 4%. So this is the perioperative mortality is 4%. Other side effects include sexual dysfunction, infertility, urinary tract infection, renal dysfunction. All this can occur, but the long-term complication of urinary diversion can occur. Recurrence after cystectomy. Local pelvic recurrence occur in less than 12% of the case. Upper tract urethral carcinoma develop in 2 to 4% of the cases when there was no carcinoma in situ in the bladders, and up to 20% of the cases when carcinoma in situ of the bladder was present in the bladder. A positive urethral margin increase the risk of urinary upper tract recurrence. So positive urethral margin does increase the risk of upper tract recurrence. Recurrence usually occur within 2 years after cystectomy. Preserving sexual function. Attempt at the preserving sexual function should only be conducted when it does not compromise the cancer control. Very important. Nerve-sparing surgery or nerve-sparing surgery. Nerve-sparing surgery reduce the risk of sexual dysfunction. Parasympathetic nerve is the neurovascular bundles at MVB are important for sexual function, and male this nerve are involved in generating an erection, and in women this nerve involved in generating vaginal lubrications, clitoral engorgements, and labial engorgements. In male, urethrectomy decrease the potency rates after nerve sparing. Nerve sparing technique avoid removal of neurovascular bundles, MVBs, and minimize the injury to the MVB. This is a nerve sparing. Nerve sparing technique can be combined with preservations of the reproductive organs. A preservation of reproductive organs in female during the standard radical cystectomy, anterior vagina, and uterus, fallopian tube, ovary, all these are removed. The reproductive organs can be spared to preserve sexual or reproductive function if does not compromise control. So these organs can be spared if it does not compromise the cancer control. To be a candidate for reproductive organ sparing, the patient must have negative screening for cancer of reproductive organs. Anterior vaginal wall. The anterior vaginal wall is in direct contact with the prostate, with the posterior bladder wall. Thus the tumor in the posterior bladder, including the trigone, can more easily invade the vaginal wall. Okay. Also, lymphatic vessels that drain the bladders, neck, traphes along the lateral vaginal wall before they enter the pelvic lymph nodes. Therefore, cancer can spread through the lymphatic to the vagina. Okay, so the lymphatic vessels drain the bladder neck, transverse along the lateral or pass along the lateral vaginal wall before enter the pelvic lymph nodes. Therefore, cancer can spread through the this lymphatic to the vagina. If the anterior vagina is resected, the vaginal reconstruction might be performed. Avoiding criteria. We have avoiding criteria for vaginal sparing. If the patient have non-organ confined cancer, that's mean stage more than 3, so we avoid to do vaginal sparing. Tumor in the bladder neck, we will remove the vagina. If the tumor in the bladder neck, we will remove the vagina. And also tumor in the trigone. So here it is very important to remove the vagina. If the tumor also in the urethra is also, we will remove the vagina. Suspicious of direct invasion to the vaginal wall, so it is a clear indication for removing the vagina. This is known as avoiding criteria for a vaginal sparing surgery. When there is no suspicion for spread of the cancer to this organ, then they might be spared. We can spare the uterus, we can spare fallopian tubes and ovaries. All this if there is no suspicion of the cancer spread to it. The ovaries may be spared to preserve hormone balance, even if preservation of sexual and reproductive function are not important. So the ovary can produce hormones, therefore it's important. Preservation of reproductive organ in male during a standard radical cystectomy, prostate and seminal vesicles, as I mentioned, typically removed. This reproductive organ can be spared to preserve sexual or reproductive function if it does not compromise the cancer control. Preservations or reproductive organ preservation, this includes prostate capsule sparing and prostate sparing procedures. This is not prostate, this is reproductive organ preservation. This includes prostate capsule sparing. Reproductive organ preservation in men remove variable portion of the prostate and the prostate capsule, but preserve the neurovascular bump, the seminal vesicle, ejaculatory duct, and the vas deferens. Preservation this organ reduces the risk of post-operative erectile and ejaculatory dysfunction. To be a candidate for a reproductive organ sparing, the patient must have benign prostatic biopsy and also a benign prostatic urethral biopsy. Avoiding criteria for reproductive organ sparing in men. We must remove all. If non-organ confined bladder cancer that is stage more than T3 and also tumor in the bladder neck, we must remove all organs that not the seminal vesicles and prostate. Tumor in the prostatic urethra also we remove all, and tumor in the anterior urethra also we remove the bladder and the lymph nodes and seminal vesicles and prostate. Prostatic cancer present we will remove. The nerve sparing without reproductive organ preservations and prostate sparing are usually effective for achieving post-operative erectile function. However, prostate sparing can also preserve fertility and ejaculatory function, even with nerve or prostate sparing erectile dysfunction occur in more than 40% of the cases. Thank you. This is the end of the lecture. We'll meet again in another one.